I'll start off with the first question. So the first question is, can you elucidate the journey for patients with single ventricle hearts, particularly focusing on palliative paths? Well, so this one I will share a little bit here. Can you see that?
Yes.
Yep. Okay. So I'm gonna just skip to this. So single ventricle hearts, it gets really confusing because there's so many different types of single ventricle hearts. Hypoplastic left heart syndrome, double inlet left ventricle, tricuspid atresia, and the list goes on and on and on. And really, although the nuances are a little bit important, they're not that important, especially at the beginning. And really all that matters is how the blood's getting out of the heart and how the blood gets in the heart. And that really determines the stages that your kid has to go through to get to Fontan completion. The goal of all of this when it comes to single ventricle palliation is Fontan completion. Now, let me just talk about this word palliation and palliative. People talk about palliative as, they think about it as, oh, my kid's gonna die. Well, we're all gonna die. That's a given. Palliative doesn't mean we're doing something temporary. Palliative means there's no way to fix this heart and make it a two ventricle situation like you and I have. It's a manufactured technique by which to get the blood to flow where it's supposed to flow. Now, depending on what kind of heart your kid is born with, that will determine how many stages of these 3 stages your kid has to go through. The prototypical single ventricle is hypoplastic left heart syndrome, and they have to go through 3 operations. The Norwood operation, which is stage 1, done in the first week of life, and then stage 2, which is the Glenn operation, somewhere around 6-8 months kind of thing. And then the Fontan operation, which nowadays is probably in the 3 to 4 year range. But there's some kids, first of all, that don't have hypoplastic left heart syndrome, that don't need a Norwood operation. There's some kids that need a different operation as a stage 1. And there's some kids that need no operation as a stage 1, and they go right to stage 2. And I call this sort of the Goldilocks phenomenon. So really what matters when your kid is born is how much blood's getting to the body and how much blood's getting to the lungs, because your children have 1 ventricle instead of 2. So in most people's hearts, there's a right ventricle that sends blood to the lungs and a left ventricle that sends blood to the body. When it's a single ventricle, there's just 1. So that's a shared responsibility. So when the kid's born, there has to be the right amount of blood getting to the lungs and the right amount of blood getting to the body. It has to be relatively equal. If it's not, then there's a problem. So if not enough blood's getting to the body, that's usually a case like hypoplastic left heart syndrome, where there's a problem with the aorta or the aortic valve or whatever, and they need a big first stage operation. If there's enough blood getting to the body, then the question is, how much blood's getting to the lungs? It's either too much, not enough, or just the right amount. Usually, if it's not enough, the child needs something like a shunt operation to get more blood flow to the lungs. If it's too much, they need something called a band operation to reduce the amount of blood getting to the lungs. And some kids are born with just the right amount of blood getting to the lungs. They have a pathway by which blood gets to the lungs, but it's restricted so that not too much blood's getting to the lungs, and they don't need stage 1 at all. So they go right to the Glenn operation and then the Fontan operation. So this is the Norwood operation, which is a big operation to repair the aortic arch, to put a hole in between the 2 upper chambers, and to put on a shunt or a source of pulmonary blood flow, either from a body artery to the lung arteries or from the heart to the lung arteries. And then so some of your kids will have undergone that and some won't have. Stage 2, everybody gets, which nowadays is most commonly the bidirectional Glenn operation. So stage 2 and stage 3 are really to divert all the work that would normally be done by the right-sided ventricle to do it without a ventricle. So the right ventricle pumps blood to the lungs, the left ventricle pumps blood to the body. If you only have one ventricle, obviously that ventricle has to do the work of pumping blood to the body. So you have to use a different mechanism by which to get blood to the lung. And that mechanism is gravity. And so there's no pumping chamber involved, which is what leads to all the late Fontan problems, because there's no pumping chamber on the right side. So stage 2, or the Glen, takes this blood vessel, which is the superior vena cava, or the blood vessel that drains all the blood from the upper part of the body. It detaches it from the heart, and it connects it directly into the lung arteries. That's the Glen operation. And stage 3, the Fontan procedure, takes all the blood from the lower part of the body, or the inferior vena cava, or the IVC, and directs it again directly into the lung arteries, this time with a tube, because that is too far away to be sewn directly to the lung arteries. So you need some kind of artificial tube. We can talk about that if you want later, what kind of artificial tube people use. But it needs a tube to direct that blood flow directly into the lung arteries. And in 2024, almost, not all, but almost all Fontan operations are done with this thing called an extracardiac conduit, which means you don't have to open the heart, you don't have to stop the heart to do this Fontan operation. You just have to disconnect this IVC from the right atrium, and so a tube from it to the lung artery. So that's the journey, that's the pathway for kids with single ventricle hearts. So if that's not clear, or if anybody has a question about it, let me know. Otherwise, I can move on to other questions. Okay, so your kids have all undergone a variety of those procedures. A lot of them I know, a lot of you, I know your kids have already had the Fontan operation, because a lot of the questions are about what's next. Some of them are in between. And so the next set of questions has to do with surgical options and considerations for single ventricle heart. So there's a lot of questions about, is it better to do a univentricular operation or single ventricle operation, or is it better to go down the biventricular route if my cardiologist has said your kid might be a candidate for a biventricular operation? So I'll give you an example. There's a kid, the question is from somebody that said, my son has a very unique heart and is currently in the process of training it to get ready for a double switch. We've been told he would also be a great candidate for a Fontan. How much would it change his day-to-day energy from going with a heart with a 2-chamber down to a 1-chamber? He's very active and doesn't show any signs or symptoms that shows he's a kid with congenital heart disease. And our main goal is to make sure he doesn't have a huge shift in his day-to-day quality of life and activities. So the natural tendency by most people, and 99% of cardiologists, is if you can do a 2-ventricle repair, because some kids are borderline, whether they can get a 2-ventricle fix or a 1-ventricle fix, go down the 2-ventricle route, because 2 ventricles is always better than 1. I'll just right out tell you that's not true. 2 ventricles are not always better than 1. 1 good ventricle is a hell of a lot better than 2 borderline ventricles. So I've seen a lot of kids that have had 2 ventricle operations that are borderline, and they end up having far more problems in the long term than if they would have had a good 1 ventricle operation. That doesn't mean that all kids should go down the Fontan route if they're borderline. There are some that are clearly better down the 2 ventricle route, some that are clearly better down the Fontan route. There's such a wide variation in anatomy and physiology that it's difficult to predict that. The double switch, for whoever asked that question, that's a tricky one, because that means your kid has, if they're considering a double switch, that means your kid does actually have 2 normal sized good ventricles, most likely. It's not a borderline situation, but a double switch, there's 2 types of double switches, and one of them is really good, and one of them ends up requiring more operations than a Fontan operation in the long term. So I'm not sure that that's really a good option. It depends which category of double switch your kid is getting. If they're getting an arterial switch combined with an atrial switch versus what's called a Rastelli with an atrial switch. The latter option is not good, the former option is. So I'm happy to answer that question offline for whoever asked it a little bit later to get more details on your child, but it's not a straightforward answer in terms of should my kid get a 2-ventricle operation or a 1-ventricle operation. But the answer is always that a good 1-ventricle operation is way better than a borderline 2-ventricle operation. So don't just think that 2 ventricles are always better than 1. Along those lines, there was a question about what types of single ventricles are best. And somebody specifically asked, is double inlet left ventricle the best? I was told that if my kid was going to have a single ventricle, double inlet left ventricle was the best. Well, that's also a difficult question. There is no real best except maybe tricuspid atresia. If you're going to classify outcomes, kids with tricuspid atresia tend to do well, but it's a little bit biased because we also have the longest follow-up on kids with tricuspid atresia. Tricuspid atresia was the original operation for which the Fontan pathway was put in place way back when. And so we have kids now that aren't kids anymore, but patients that are 40 and in their 50-year age groups that have tricuspid atresia that have gone down the Fontan pathway. So it's a little bit difficult to tell. The reason you might have been told double inlet left ventricle is a good category is because it's a single ventricle that has a systemic left ventricle. There's some kids like hypoplastic left heart syndrome where their dominant ventricle or their only functional ventricle is the right ventricle. And there's some kids like double inlet left ventricle or tricuspid atresia whose dominant ventricle is the left ventricle. Now, if you're going to choose, if God came to you and said, your kid's going to have one ventricle, do you want it to be a left one or a right one? You're going to pick left because the left ventricle is built differently than the right ventricle. The left ventricle was designed to pump blood to the body. The right ventricle was designed to pump blood to the lungs. They're built differently. Their muscle architecture is different. And so the right ventricle wasn't designed to pump blood to the body for a life expectancy of 80 or so odd years, where the left ventricle can. That doesn't mean that every kid that has a systemic left ventricle is going to do better. And that doesn't mean that every kid that has a systemic right ventricle is going to do worse. But there's certainly a bias there in terms of kids that have a systemic left ventricle doing better in the long run. There's a lot more factors that come into play when you're talking about long-term Fontan success. But the ventricular morphology is just one of them. Now, there was another specific question, a unique case. Let me find it. My son, who had a Norwood, has a partially occluded SVC or superior vena cava and doesn't qualify for the Glen. We've upgraded his shunt and we're told he's eligible for a Fontan once he reaches the weight requirement. Do different variations pose higher risk for long-term complications? Okay, well, to answer that question, you need to understand that when the Fontan was first devised, it was a one-step operation. So yeah, people or kids got a Norwood if they needed it, but those that didn't, they didn't get a Glen and then they got a Fontan. They got the Fontan, which was the Glen plus the Fontan. That's how it initially started. The mortality was very high. A lot of kids died. And it was only after surgeons discovered that if we split these things up, if we just do the upper half first and call it the Glen and the lower half second and call it the Fontan, the kids do much better in the short term and the long term. And so that's a much better way to look at it. Now, eliminating the Glen and just doing the and the reason that you do the Glen first is because of proportional blood flow. So as you probably have figured out, children have a much bigger head compared to their body size than adults do. So there's a lot more blood coming from the upper part of the body to the lungs when you're a small child as opposed to when you're an adult. or even an adolescent or a teenager or whatever. So there's a lot more bang for the buck in terms of oxygen saturations if you do the Glenn first. Not many people have tried to do the Fontan first and do the Glenn second. It just doesn't intellectually make sense. If there's a reason you can't do the Glenn because the SVC is occluded, then I suppose you can go with the Fontan as your only option. It does carry additional risk. And if I was the parent of that situation, I would be asking the cardiologist, are there other options? Is the Fontan route the best option, or is the transplant route a better option? When I mention the word transplant, people often think that's a failure. It's not. It's harder in the sense that you have to get a donor heart and you have to go through that whole pathway. But honestly, if you all had kids that had a single ventricle and on day one of life, somebody came to you and said, we have hearts for all your kids. We can replace all your kids' hearts with a 2-ventricle heart and a transplant, or you can go down this Fontan pathway. If you want to look purely at the data and the outcomes are better for the transplant group. So it's not a failure. It's a different pathway. Now that's if you're starting off as a baby. It gets a little bit nuanced when you're talking about older children, but that's not necessarily a failure, and I don't want people to think of it that way. So not that just doing a Fontan without a Glenn is not an option. It is. It's an unorthodox option. And so I would just encourage whoever asked that question to just pimp their cardiologist a little bit about what they think the benefits are of that versus a transplant pathway. You're certainly going to get less of a saturation rise than you would had you had just a Glenn or a Glenn plus a Fontan. There was also a question about the weight, WEIGHT weight, not length of time, in terms of the optimal weight to get a Fontan. My kid's so-and-so weight, should I wait longer or should I get it now, etc. So again, that has to do with the type of Fontan that the surgeon's doing. Like I said before, most surgeons in this day and age do the extracardiac Fontan, which means you're putting a prosthetic or an artificial conduit between the inferior vena cava and the pulmonary artery. That artificial conduit is a non-growing tube. So that changes the time at which the Fontan becomes optimal. When we used to do different types of Fontans, they carried other risks, but part of the benefits of them was that they grew because part of the Fontan conduit was made up of the kid's own tissue. In the extracardiac conduit, it doesn't grow. So what we like to do is wait until the child has the size at which the inferior vena cava will no longer substantially grow, is already an adult size IVC. And we think that's about 15 kilograms. And at that point, you can put in a conduit that's big enough that they won't outgrow it. Doesn't mean some kids won't need a new conduit, but it's very rare that they'll need a new conduit later on in life. So if you can wait till they're 15 kilograms, that's the best case scenario. It's not a golden magic number. Like I've operated on plenty of kids at 13 kilograms or 14 kilograms, and some even earlier if they tell me they need the operation earlier. That means the kid tells you because their saturations are too low, their exercise tolerance is poor, all that kind of stuff. But you have to really make sure that they're getting an expedited Fontan for the right reason. There was a question in here about a child that had diminished ventricular function. It was on 2 drugs, I think enalapril and carvedilol for their heart function. And in terms of timing, yeah, she has low normal function, but is overall doing well. Low normal function is a risk factor when it comes to the Fontan, even if they're doing well. So that's not a reason to expedite the Fontan. If anything, it's a reason to delay it because you want to optimize ventricular function as much as possible to be able to tolerate that extra blood load that's going to happen when you do the Fontan operation. That heart is going to have to pump a lot of extra blood that's now coming back from the lungs. Now, let me just do.
There's a couple questions that have come in. I don't know if you
Okay,
saw them or if you want me to.
Yeah, no, I didn't have my chat open. Here we go. You mentioned that tricuspid atresia is the best to have. Our daughter has pulmonary atresia. How similar are those two, or how do they differ? Well, they're totally different diseases, but they can result in the same sort of thing. So tricuspid atresia is a good diagnosis, again, for two reasons. One, because the ventricle that the child has is a left ventricle. And you have to realize that the ventricle that they have depends on the valve that's malformed. So tricuspid atresia is the valve between the right atrium and the right ventricle. So when that doesn't develop, the right ventricle doesn't grow. In hypoplastic left heart syndrome, it's the mitral valve that doesn't develop, so the left ventricle doesn't grow. In pulmonary atresia, that's usually associated with a small tricuspid valve. So it's akin to tricuspid atresia in that it's the left ventricle that's usually the dominant ventricle. Pulmonary atresia is a completely different kettle of fish, though. There's a lot of different types of pulmonary atresia, so I'd have to know a little bit more of the specifics of your child, Natalie, but it's good in that they have a systemic left ventricle. My son is a single ventricle, double outlet right. He had his Fontan at age 5. We were 4 years post-Fontan. Do you have Fontan surveillance plan recommendations? Yeah, I'll get to that in a minute. Is the Fontan surgery more difficult when the IVC is left-sided? Good question. My daughter has right atrial isomerism with left-sided IVC and SVC, right-sided aorta and pulmonary veins, unbalanced AVSD, et cetera, et cetera. Yes. So it depends where the heart is. It's not more difficult if the heart cooperates. So when the IVC is left-sided as opposed to right-sided, and the heart is right-sided, then it's just a mirror image. The problem becomes when the heart's left-sided and the IVC is left-sided, because then the heart gets in the way. And then you have to be a little creative about things. And there's different ways to be creative. I've done a lot of Fontans and a lot of heterotaxy patients. And so you just have to be creative. And there's lots of different ways you can rejig the geometry. It would be good for you to get an idea from your surgeon how they're going to rejig the geometry so that they know what they're doing before they start doing it. Her heart is left-sided. Yeah, so that is a bit more of a problem because that means the Fontan can't go on the left side. So then you have to move the IVC and make the Fontan a right-sided conduit or pathway. That's entirely doable, but it's important that that be done because if not, the Fontan conduit's going to lie behind the left ventricle or the heart, and it's more prone to getting obstructed because it's getting pushed on with every heartbeat. So there's ways to mobilize the inferior vena cava. Mobilize means freed up from the surrounding tissue and move it over so that you can make the conduit go towards the right side. And there's different kind of conduits you can use too. A lot of surgeons use just a piece of what's called Gore-Tex, which is like a plastic tube. I never used to like those for a lot of reasons, but I used a piece of aorta from a cadaver, so a homograph, an aortic homograph. And the reason I like that is because it had a natural curve in it and it was more malleable. So you could bend it whichever way you wanted to bend it. It was less prone to clot and all that sort of stuff too. But there are lots of little tricks you can use to get the Fontan conduit over to the right if the heart's on the left. Good question. My son is waiting to find out if he'll need the Fontan. He's almost 4. He has pulmonary atresia, intact ventricular septum, hypoplastic right heart, and an ASD. Yeah, so that's another difficult one to answer without knowing the specifics because there's so many types of pulmonary atresia, intact ventricular septums. Some of them have a normal right ventricle. Some of them have a completely useless right ventricle. And some of them have a borderline right ventricle. And in that specific situation, your child is a candidate for 3 potential different pathways. The single ventricle or the Fontan pathway, the biventricular repair, which means the right ventricle is good enough, or if the right ventricle is okay, but not great, you can do this thing called a 1.5 ventricle operation, where you allow the right ventricle to pump blood to the lungs, but you don't close the atrial septal defect. So there's a way for blood to escape. And that's probably, if tolerable, a better option than the Fontan. But it all depends on the size of the tricuspid valve and the size of the right ventricle, which is very variable in kids with pulmonary atresia and intact ventricular septum. Okay. The other thing you have to realize with pulmonary atresia and intact ventricular septum is that you're not going to have a functional pulmonary valve at the end of the day. And that will likely mean a bunch more operations as the kid gets older. That's why I said that 2 ventricles are not always better than 1. Some 2 ventricle repairs end up meaning a lot more operations down the line to replace the pulmonary valve or the conduit between the right ventricle and the lungs than would be the case with a Fontan pathway, where in most circumstances the operating ends after the Fontan operation. Okay. Let me make sure I got these. Advancements and research in single ventricle heart conditions. So what research findings can you share about Fontan procedure outcomes in adulthood, including trends in Fontan failure and the necessity for transplants? And this was a question that was asked a lot in different manners. Are there emerging technologies or surgical advancement that could enhance the quality of life for single ventricle patients? So that's the $1 million question. The one that nobody really has a great answer to. And the reason is because this is all relatively new in the world of medicine. Like we talked about last time, congenital heart surgery is a new specialty. It's 70 years old. And single ventricle kids are the newest of the new in terms of that specialty. Like for the first 20 or 30 years of congenital heart surgery, if your kid was born with a single ventricle, they just didn't live. And it was only when the Fontan operation became refined and people got better at it and there were different ways of doing it that success started to come about with children with single ventricles. And the Fontan has undergone, in my lifetime, 4 different major variations. From when I was a resident to when I stopped doing heart surgery, there were 4 different ways we did the Fontan operation. The last probably being the best, the extracardiac Fontan. There were still older versions of the Fontan that I used in specific anatomic circumstances, but all of those evolutions were based on a lot of research over the years, both research in terms of real life patients and research in the lab that had to do with the engineering or blood flow in the Fontan circuit to prevent blood from clotting, to make sure it passed from the Fontan circuit to the lungs in the most hemodynamically ergonomic, efficient way as possible. And that's how surgeons came up with this extracardiac business. And I'm sure as time passes, there will be more modifications to the Fontan operation that are even better. There will be different conduits that are used that are better than ones that have been used in the past. And there will be mechanisms by which to augment the single ventricle circulation. So the biggest problem, as I alluded to before with the single ventricle circulation, is that all the blood on the right side is getting to the lungs through gravity. There's no pumping chamber. And that's what leads to all the problems with the Fontan later on in life. Now, there have been a lot of experimental models with devices that can be put in the circulation to artificially pump blood. It doesn't necessarily always pump it, but it can accelerate or augment the flow of blood through the Fontan circuit. Like there's little devices that have been tried in animals that you can put in the right-sided circulation that spin like a little rotor and allow blood to get to the lungs in a more efficient, energy-efficient manner. And I'm sure there will be more developments like that. Whether they're in my lifetime, I'm not sure. Whether they in your lifetime, I'm not sure. They might be in your children's lifetime, though. So there's a lot of those things that are being worked on. and I'm sure that the technology will continue to get better and better. For now, though, unfortunately, it does rest upon medical professionals to follow up Fontan patients diligently over the years, to look out for and try to mitigate against Fontan complications, which was sort of the next series of questions. So what complications are we talking about? Well, there's a whole set of them, and they all have to do with the lack of a pumping ventricle and the fact that the blood vessels on the right side are sewn directly to the lungs, meaning the pressure in those blood vessels is necessarily higher than it would be if there was a pumping chamber in between. That means that the central venous pressure, or the CVP, is higher in your kids than it is in you or me. So if you look at their veins in their neck, they're more prominent than the veins in your neck, because the veins in their neck are attached directly to their lung arteries. Now, with time, that may become less obvious. Initially, it's a little bit more obvious. And that leads to, for lack of a better way of saying it, backup of blood in all the organs of the body that empty into the right side of the heart normally, but in your children, empty directly into the lungs. So the one that's most closely attached, the one that's in most close proximity, is the liver. And that's why the liver tends to be the organ that's worried about the most long-term in the Fontan circulation, because it sees that higher central venous pressure all the time and directly. The inferior vena cava, which is the blood vessel hooked up to the lungs in the Fontan, comes from the liver. The hepatic veins, or the veins that drain the liver, all coalesce to form the IVC, which is then connected to the pulmonary arteries. So every kid that's had a Fontan, every single one, and this isn't meant to scare you, it's meant to tell you the truth, every kid is going to have liver changes at some point. The question is, are those liver changes significant or not? And that's the question that nobody really knows the answer to. I can tell you that, having done plenty of heart transplants on kids that have had Fontans, all of their livers are a problem at the time of the Fontan. But that doesn't mean they're a big enough problem to have to do anything about. That just means that they're different than a kid that hasn't had a Fontan. Some of those livers worked absolutely, totally fine. Some of them were borderline. Some of them didn't work well at all. And some of them that didn't work well at all were reversed by having a normal heart put in. Some of them weren't. So it's a big spectrum, and it's something that's evolved a lot in the last couple of decades in terms of monitoring the liver. So now all your kids should be getting routine surveillance of the liver. What does that mean? It means at minimum, they should be getting blood tests of the liver. The problem with the blood tests is that they don't always tell the answer. If your liver blood tests are off, that probably means you're too far down the pathway, or it means that the liver damage has already started to happen and you want to sort of intervene before that. And so there are different kinds of ultrasound tests. They're called elastography, or you might know them as a FibroScan, and they detect fibrosis, which is scarring in the liver. And different institutions have different protocols for how often Fontan patients should get a FibroScan, but there should be some protocol set up where every so many years your kid gets a FibroScan and you can compare FibroScan from 2024 to FibroScan from 2020, et cetera, and know if there's progression of liver disease. So all of that stuff should happen. There should also be, of course, routine echo surveillance of the Fontan circuit to make sure the blood's flowing like it's supposed to flow. The kids all have conduits going in from their IVCs to their pulmonary arteries. They're all susceptible to clot. There's different protocols for blood thinning depending on what hospital you were in. Some people use Coumadin, a powerful blood thinner. Some places use aspirin, some places don't use anything, some places use a combination of medications. The fact that there's so many different protocols just means that nobody really has the answer. There have been lots of studies done, and there have been no real hard data that's come about to say that one is better than the other. When I started, we used to give everybody Coumadin. Then I figured out there were too many Coumadin complications, and there's really no data to show the Coumadin is any better than aspirin. Aspirin's a hell of a lot easier, and it's just easier to take, and it's just as efficacious as Coumadin when you actually look at the information that's out there. So I always suggested that kids get aspirin after their Fontans, and I always suggested that they get it for the rest of their life. I know a lot of cardiologists stop it after 3 months or 6 months or a year, and it's, again, it just goes to show that there's no universal protocol for that. But they should all get routine echo surveillance. They should all get routine liver surveillance. And based on those things, they will likely need intermittent cardiac catheterization at various points during their life. That doesn't mean they need one every year. That doesn't even mean they need one every other year. But they will need cardiac catheterizations at some point in time for the rest of their life to assess their Fontan circuit, to assess the pressures inside their heart and inside the Fontan, and to figure out if anything needs to be done. Okay, I think I answered the blood pump question. Fenestration. Okay, so what's a fenestration, first of all? So a fenestration is when you keep a connection between the right side of the heart, or the Fontan pathway, and the left side of the heart, or the pumping pathway. So in essence, how that's done is a hole is created between the Fontan tube and the upper chamber of the heart, which is a common atrium, so that some blood that goes through the Fontan will escape through that connection or hole and get directly to the body. So it won't go through the lungs. So what are the upsides? The upsides are that it's referred to as a pop-off valve, so that the lungs don't have to absorb all of the blood that's now coming from the lower part of the body. But the downsides are that some of the blood's never going to see oxygen. So the oxygen saturation numbers won't be as high. The other downside of the fenestration is there's always a connection between the right and the left sides of the body. So any little clot or whatever that develops on the right side of the body can get to the left side of the body. It's got an easy way to get there, and that leads to the potential for stroke. So patients that have fenestrations have a higher stroke potential in the future, and they have lower oxygen saturations. And that's the reason that fenestrations get closed. So most fenestrations that don't close spontaneously, and some of them just close off on their own, they should get closed unless there's a compelling hemodynamic reason, meaning there's a borderline situation present that's going to make life bad for your child if the fenestration is closed. Most of the time, if that exists, then they probably weren't a great Fontan candidate to start with, so you really have to wonder about it. But there are a lot of benefits to getting the fenestration closed, but there's no rush to it. It should be done when it's supposed to be done. The next question is, do kids that stay as a Glenn avoid the liver disease? The answer is yes, they do, but they also stay blue because there's a lot of blood that will never see the lungs unless they have anatomy that allows some of the blood from the right side to get to the lungs, which means they're kind of like a 1.5 ventricle circulation. If that's the case, it's perfectly fine to stay a Glenn forever and ever. If that's not the case, if there's no way for IVC blood to get to the lungs, then your kid's going to get blue and blue and bluer. And at some point, they'll start to feel the effects of that, meaning exercise intolerance, worsening cyanosis, and a decreased quality of life. So they will need something done if they can't get IVC blood to the lungs naturally. Liver failure, I think I talked about. How should the liver be monitored? I talked about. There's actually a really good summary paper on that that's available online for free. Let me see if I can share it here. It's this paper from Circulation, Fontan-associated liver disease. And I don't have the link, I'm sorry, but it's from Circulation. If you just Google Fontan-associated liver disease and Circulation, you'll come up with this paper, because that's how I did it.
We can email this out afterwards as well. If you
Okay.
have the PDF of it, we can certainly share that if it's of
Okay.
interest.
Yeah, perfect. And there's lots of complicated charts in there, but it does go over the general liver surveillance that most kids with Fontan should get later on in life. So the next questions were about things like quality of life. Have you seen quality of life differ for these patients? Diet, exercise, cognitive ability, social interactions, et cetera, et cetera, et cetera. Well, I'll give the answer that I always give in terms of kids and heart disease, is that you should treat them like normal kids. Like, let them do whatever they want. If they want to go jump out of a plane, let them go jump out of a plane. I'm being serious about that. Like, they will limit themselves. Their exercise tolerance as single ventricle patients is not going to be normal. They're not going to win a gold medal in the Olympics. If they do, then all the more power to them. But chances are they're not going to win a gold medal in the Olympics. That doesn't mean that they should be limited in their activities. They will limit their own activities. The point of all of this, from my perspective, now that I'm old, is that the point of this is not just fixing their hearts and getting them to live. It's getting these kids to be normal children, normal adolescents, normal teenagers, normal young adults, normal people. And I've seen plenty of single ventricle patients that have gone on to live normal lives. I can't tell you that their quantity of life is normal, because we just don't have those statistics yet. But I mean, I worked with a nurse for the longest time in the United States that was herself a Fontan patient. And she was in her 30s. And that was, well over 15 years ago. And I worked with lots of different people that had Fontans that lived normal lives as much as they were able to do so. And if they had their shirts on and they didn't show you their scars, you really couldn't tell the difference. So in terms of exercise tolerance and things like that, they will limit themselves. Cognitive ability, social interactions, that really has to do with your children more than it does with your children's hearts. So there's plenty of two ventricle people out there that are socially awkward. That doesn't mean, just because you have two ventricles doesn't mean you're going to get a girlfriend or a boyfriend faster. And as far as things like diet and stuff go, there's no difference between single ventricle patients and patients that have a so-called normal heart. They should all eat heart-healthy diets, as far as I'm concerned. Is it more important for single ventricle patients? Well, theoretically, maybe, but there are plenty of all this acquired heart disease that exists in the world. All that acquired heart disease exists in patients that have structurally normal hearts. So, of course, you don't want your Fontan kid to also have coronary artery disease later in life. So it's even more important for them to have a lifestyle that protects their heart as much as possible. But it doesn't have to necessarily be different. That doesn't mean your kid can't eat pizza, and that doesn't mean they can't indulge. They should live normal lives and let them limit themselves. Maggie is 17 and heading to Zambia. That makes me happy. And I know Maggie eats lots of hot dogs.
She's right here. Did you see her?
Hey, Maggie, how are you?
Hi.
Grown up. I haven't seen Maggie since she was like 3 or 4 years old. The hot dog story is, Maggie, did Maggie have a chylothorax? No.
Mm-hmm.
She did.
Yeah.
She was on a low-fat diet for a while, and I walked into her room, and lots of times the food when you get a low-fat diet is disgusting, and lots of times there's a mistake. Like, I walked into patients' rooms where there's mac and cheese, and they're supposed to be getting a low-fat diet, and so I walked into Maggie's room. I don't remember the exact details of the story. I just remember this hot dog, and it was disgusting looking. And I asked if it was low fat, and I think Faith, who's Maggie's mom, said it is low fat, and I said I needed to try it, And I tried it and made an awful face because it was disgusting. And
Yeah, you didn't believe us.
I didn't believe you. Yeah.
No.
I don't know if I believed you after I tried it or not. Anyway, there was a question: are further operations often necessary to extend lifespan? So that, I didn't understand if that question meant lifespan of the child or the patient or lifespan of the Fontan. Regardless, I guess the answer is still the same. Most of the time, the Fontan's the end of it, unless a kid needs a heart transplant. Now, there are times when there's problems with the Fontan circuit itself. Kids outgrow the Fontan because the conduit that was put in was too small, or there's problems that develop in the Fontan that require it to be replaced. And that's why kids need constant surveillance. But I gotta say that the incidence or prevalence of that happening is awfully low. So it's not zero. I have reoperated on Fontan patients, but mostly it's because the Fontan conduit that was put in at the time was just too small. So if any of your kids haven't had a Fontan yet and they're about to get one, you should ask the surgeon what size conduit they're putting in. And if they don't say at least 18 millimeters, then it's too small. It should be 18, 20, 21, 22 millimeters. That's the size of an adult inferior vena cava. If it's anything smaller than that, then they're going to outgrow it. The next set of questions has to do with more general stuff. Oh, there was another question about pregnancy. What recommendations do you have for pregnancy in patients with hypoplastic left heart syndrome? And how can their cardiac and overall health be best managed during this time? So that's a great question. And it's another one where the answers are not all there. So if you asked me this question 10 years ago, the standard answer was don't get pregnant. The answer is birth control. And I'm sure that most cardiologists would say things along the same line today. So what's the issue with pregnancy, as all of the moms know here, is that pregnancy is a stress on the body. So it makes your heart work 30% harder on average by the third trimester. There's a lot of extra blood getting back to the heart. There's a lot of extra what's called preload because of all the extra blood from the fetus and the placenta. And so your heart has to be able to tolerate that. So if you only have one ventricle instead of two, it's obviously going to be harder to tolerate that extra stress. That doesn't mean you can't get pregnant. It does mean that that patients with single ventricles have to be selective when they get there has to be a selection there. So you have to be properly evaluated, or should be properly evaluated by your cardiologist in terms of how the Fontan circuit's working, what the function of your heart is. If you've had any other complications like arrhythmias. Arrhythmias are a big no-no when it comes to pregnancy in the Fontan because the incidence of arrhythmias goes way up if you've already had them and then you get pregnant. And then with arrhythmias come clots, and there's a significant risk to the mother with that. So you have to make sure that your heart status is good to start with. And then there's a lot more monitoring that's necessary, and you really need to be attached to somebody that knows about that stuff, knows what needs to get monitored, and needs to get monitored closely during the pregnancy. There are lots of reports out there about patients with Fontans having successful pregnancy, but they're reports. There's no big series of 200 or 500 patients that I can point you to because it's just not that common. So the standard textbook answer is don't get pregnant. You can still have kids by other mechanisms, but don't get pregnant. But that doesn't mean that it's completely 100% eliminated. It just has to be done cautiously, carefully, and with proper surveillance. How can parents and caregivers support children with single ventricles as they enter their teen years and transition to adult care? This is similar to a question that was asked a few weeks ago. And it's that transition to adult care that's the issue. And so I think kids need to be supported as much as they want to be supported and need to be supported. And you have to be advocates for your children just like you were when they were underage, when they transition to adult care. The adult care transition is a very tenuous time. And the adult world is not consistent in terms of how congenital heart disease is cared for. Some places have better systems in place than others. They're more attuned to problems that kids have undergone and the kind of care that they've received. Some are not. They just assume that once they turn the age of 18 or 19 or whatever magical age that institution deems the child to have turned an adult, that they're all of a sudden an adult and they can take care of all of their medical needs by themselves and they don't need mommy or daddy anymore. And that's just not true for, I would say, the preponderance of kids that have undergone Norwoods, Glens, and Fontans. They still need the support of their parents. So being a bit pushy about it, being a bit in your face to the new doctors that are taking over, there's nothing wrong with that. You might piss a few people off, but like, I know that you've pissed people off in your life, all your entire lives, and you should continue to do that. And that's, you're only looking out for your children. So just continue to be advocates for your children. Don't take no for an answer. This last question I'll answer before I'll stop is, why is there not more Canada-wide collaboration to establish focus centers of excellence for specific procedures rather than a province-specific approach? That's a good question, but I want to put it in perspective. Because Canada, and no offense to the Americans in the audience, does a much better job when it comes to regionalization of pediatric cardiac care than the United States. So in the US, there's a congenital heart program on every block, almost literally. And the reason is that congenital heart programs are traditionally the biggest money makers in children's hospitals. So everybody wants one. And that doesn't mean everybody should have one, but everybody wants one. When you have that many, it leads to dilution of quality of care. Some places are fantastic. Some surgeons are great. Some places are less than fantastic, and some surgeons are less than great. In Canada, because of what happened in the 1990s, and if you don't know about it, you can Google it, but there was a big controversy in the 1990s in Canada that led to a lot of programs getting shut down in Canada and pediatric cardiac surgery being regionalized to where it is today, where there's very few programs nationwide. There's basically surgical programs. There's Vancouver, there's Edmonton, Toronto, Ottawa has a small program, Halifax, and there's 3 in Quebec. And the only reason there's 3 in Quebec is because of the French-English thing, but that's it, that's Canada. There used to be a program in Manitoba, it got shut down. There used to be a program in Saskatchewan, it got shut down. There used to be a program in Hamilton, it got shut down, all in the early 90s because of quality of care. And so Canada already does a better job. That doesn't mean that it couldn't do an even better job. And that's sort of the role of parents when it comes to specific operations in terms of vetting who's doing your child's operation and is there somebody better to do it. Obviously, it's difficult to travel, and social supports aren't always there when you have to go out of province or across the country to get an operation. But you should, at the end of the day, you should do what you think is right for your child, because you're the one, and your children are the one that have to live with those decisions for the rest of their life. So it doesn't mean that you have to go out of province. The grass is not always greener somewhere else, but just do your due diligence and try to figure out as much as you can beforehand. I'm not going to answer the question that 3 or 4 people asked in terms of who's the best surgeon to do the Fontan operation. So there's this kind of joke about heart surgeons when you ask them that question. So if you ask a heart surgeon to name the top 3 surgeons in the world, usually a good heart surgeon will have a hard time naming the other 2. So I'm going to leave it at that. Anyway, any other burning questions or anything that was confusing or anything else that people want to ask? I know that I didn't answer everything, but I think I got to most of it. It's really nice to see a lot of familiar names. It's even nicer to see a lot of unfamiliar names, which means that the message is getting out. And I hope the message continues to get out. Like this forum is supposed to be to help parents and give them a sounding board. So we're going to continue it. So hopefully this has been helpful. And I'm more than willing to take suggestions, criticism, feedback in terms of how we can make this better, what you liked, what you didn't like. And again, it's just a mechanism by which you guys can get information that you might not be able to get elsewhere.
No, I think I can speak for all of us. We appreciate it. I learned something in every single one of these sessions. I'm sure other people did as well. So thank you.
All right. Have a good night, everybody.
Thanks, everyone.